I'm Eileen Consorti. I'm director of the Carolan Reed. I'm really happy to bring you the San Antonio update tonight. Anxious to hear what was discussed in San Antonio in December. But before we get going, we have a couple announcements. The first announcement is the speaker series for the Carolan Reed. We're going to bring it to the community. Before we've been having them at San Merit for a series of about 6 talks a year, and I thought the best thing to do is to pull it out of San Merit and bring it to you. So, and obviously it's working because it's pretty well attended. So thank everybody for being here. This is the first time we've used this venue. If you have any comments or suggestions, we really welcome you filling out that critique at the end, evaluation at the end, so we know how you felt it went. That's super important to us. The next Breast Cancer Forum will be March 15th. We're going to take it to Impact Hub, which is on Broadway. That's a really nice venue as well for community talk. And it's going to be about making decisions about breast reconstruction. And it's given by David Chang and Gabriel Kine, 2 great breast reconstructive surgeons. So we're really excited about hearing that talk on March 15th, if you want to mark that down. So that's as far as it goes, and I'm going to do the introductions. We have a nice group of speakers tonight. The first speaker is Dr. Goodwin. I'm going to introduce her, and then I'll come back and introduce the other 2 speakers, and then we're going to have Q&A at the end. Oh yeah, and the last announcement is this is the very first time we have a videographer who's going to videotape the talk tonight, and we're going to post it on the Carolan Reed website. So people who couldn't make the talk, and I've heard this from a lot of my patients, saying I really wanted to go to the talk, but I couldn't make it. Is there a way I can see the talk? So this is a great way to access the talk on the Carolan Reed website. We're going to post that videotape of tonight's presentation. To introduce Dr. Goodwin, she graduated from the Miami University in Oxford, Ohio, with a degree in zoology. She served 2 years as an AmeriCorps member with the National AIDS Fund in Washington, D.C., and then decided bravely to go on and receive her medical training, and has a DO from Touro University. She did residency in Des Moines, Iowa, which is pretty icy, I'm sure, this time of year, and a breast surgical oncology fellowship in Washington, D.C. She's a member of the American Society of Breast Surgeons, American Society of Breast Diseases, Society of Clinical Oncology. She's a breast surgeon in Oakland, treating breast cancer and benign diseases of the breast. Welcome.
Hello there. So I think the one thing, we're going to try to hold questions for the end, so when we're all done we can ask as many questions as possible, but if there's something you just have to ask, either write it down or raise your hand and we'll make sure we come back to it. So go ahead. So I have no disclosures about this talk. So today we're going to talk about the surgical updates from the San Antonio conference that was back in December. So we're going to talk about kind of 4 main things from a surgical perspective. We'll talk about the actual surgical changes, surgery in the neoadjuvant patient, so the patient that gets chemotherapy before their surgery, how that affects surgery, localization for non-palpable breast cancer, and then a little bit about some new technology that's coming down the road. So the first talk that I want to kind of focus on, the first 2 I'm going to spend most of the time on, and this first one was given by a surgeon from Sloan Kettering in New York, Monica Morrow. She talked about changing paradigms in the local therapy of breast cancer, making less more. And we've made a lot of advances with breast cancer over the year, as many of you know, including diagnosis, how we diagnose breast cancers, and also a lot of the ways about how we treat breast cancer. So we know that cancer is now being diagnosed at much earlier stages than when we used to not have the screening tools that we have now. We've made a lot of advances with systemic therapy, which Dr. Marshall will talk about when she talks about the changes with medical oncology. And some of this is due to new chemotherapeutic regimens, targeted therapies for specific types of breast cancer, endocrine therapy recommendations, whether we give something for 2 years, 5 years, 10 years, however long, and a lot of radiation changes that Dr. Yu will talk about tonight. We've also seen the loco-regional recurrence, which is the recurrence in the breast or the lymph node region, come down over many, many years, from over 30% to much less than 15%. And so there have been kind of two major studies in the past few years that have sort of helped in our advances and that have really changed a lot of the ways that we operate when we're talking about taking care of breast cancer. And the first is this ACOSOG Z11 study that we'll go into, and then also some new consensus guidelines that came out about 1.5 years or 2 years ago regarding what type of margin do we have to have when we take someone's cancer out via a lumpectomy or partial mastectomy. So just to go over, this is kind of how things started. As you guys may know, years and years and years ago when we took patients to the operating room for breast cancer, we used to remove all the lymph nodes underneath the arm. That was just standard. And then we kind of learned that, well, maybe we don't have to do that. Maybe we don't have to subject everybody to the risk of possible lymphedema and swelling in the arm that sometimes happens when we remove everybody's lymph node. So then we started doing a sentinel lymph node biopsy, which is kind of removing that first 1 or 2 or 3, maybe even 4 lymph nodes that drain the breast. And we found that if those were negative, there was no benefit in removing the rest of the lymph nodes under the arm. And so that's kind of where we're at standard. For an invasive cancer, we check those lymph nodes, and we used to say, well, if they're positive, we should take the rest out, and if they're negative, we don't have to do any more surgery. And we've made some advances through this Z11 study. So what this study did is it looked at women that had early stage breast cancer, a tumor in the breast less than 5 centimeters, and it randomized patients to get only the sentinel lymph node biopsy or a sentinel lymph node biopsy plus removal of all the lymph nodes, the axillary node dissection. And what it looked at was if a woman has 1 or 2 lymph nodes that actually have some cancer in them in the sentinel node biopsy, is there a benefit in removing the rest of the lymph nodes, or do women do the same if we leave those lymph nodes there? And actually what they found is that if there's 1 or 2 lymph nodes that have a little bit of cancer, and this was in the setting of lumpectomy only, not mastectomy, and that cancer hadn't broken through the wall of the lymph node, then there was no survival benefit and there was no difference in recurrence if we remove the rest of the lymph nodes or if we leave the rest of the lymph nodes there. And that's really changing the paradigm of how we operate, because we were so regimented on positive lymph node, they must all be removed. And now we're kind of shifting a little bit away from that. So the median follow-up of this was only 6.3 years. And again, they showed that there was really no difference in the recurrence of breast cancer in the lymph nodes in the patients that had all their lymph nodes removed versus the patients that just had their sentinel lymph nodes removed. And this was no difference in their disease-free survival, in the chance that they got this again, and in their overall survival. And yet the women that had just the sentinel lymph nodes had much less problems with lymphedema and paresthesias. But there were a lot of concerns when this study came out a couple of years ago saying, oh, the follow-up is too short, this is not long enough to tell us whether this is really valid. And it was a pretty highly favorable population. These were women with smaller tumors that were estrogen positive, only at that time looking at invasive ductal carcinoma. And they questioned like, well, what if, can you use this for women that have different types of cancers like triple negative, HER2 positive, and they weren't sure. And they weren't sure if this was going to be applicable for these higher risk women. So one thing that was presented at San Antonio this year was a Z11 update, which looked at nodal recurrence for taking this out to almost 10 years, so 9.2 years. And what they showed is there was really no difference. The 10-year cumulative nodal recurrence rate was actually very similar. There was only 1 recurrence after 76 months. And so I think what we're finding is actually less is more in terms of surgery. Maybe we don't need to remove all these lymph nodes in every single case if there's 1 or 2 positive nodes. And so then Memorial Sloan Kettering did their own validation study just to see. They have so many high numbers of patients that come to them, and they said, okay, so that's what the update showed from all of the centers around the US that participated in Z11. Let's see if our data is the same. And so they used that same data, and they had 774 eligible patients, and 85% of those patients went on to only have the sentinel lymph node biopsy. They were using those guidelines that came out with the Z11 study. They did exclude about 15% of the patients because either they didn't meet the criteria for one of those reasons, they had chemotherapy before surgery, or they had a small amount of disease in the lymph node, or they had had a mastectomy, which did not qualify for this study. And they looked at high-risk women. They looked, well, can we apply this to women younger than 50? Can we apply this to women that have triple-negative disease or HER2-positive disease? And again, on average, 85% of those patients went on to only have sentinel lymph node biopsy. And then they also looked at how the radiation was delivered, because as Dr. Ewell might touch on, radiation can be delivered in multiple different ways. You can be lying on your back, lying on your stomach, lots of different ways. And so they looked, and in their study, about 60% of the patients were given the standard supine, lying on their back radiation, 22% were lying on their stomach, and 19% of the patients actually got radiation to their breast and their lymph node area, which was not a definite criteria in this original Z11 study. And they looked at their median follow-up, and they had no axillary recurrences. They did have 3 recurrences that happened both in the breast and the lymph node area, and 2 that ended up with metastatic disease. But their 5-year nodal recurrence rate was, nodal recurrence-free rate was 98% when they applied all of this data to even their high-risk patients. So I'm going to switch route just a little bit and talk now about the new consensus on margins in invasive cancer. So previous to these guidelines coming out, there really was no consensus surgically on what defined a negative margin. So if you said, okay, we got your cancer out with a negative margin, you didn't really know if 1 millimeter away from the cancer was okay, or did you need a centimeter away from the cancer to call it a negative margin? We really didn't know. And we were sort of just using arbitrary numbers to say, yeah, I think we're far enough away from that cancer that it won't come back. So this was a meta-analysis looking at 33 studies and many, many patients looking at trying to define what constitutes a negative margin. And they found that the definition of a negative margin should be what we call no tumor on ink, meaning when they look at the cancer under the microscope, those tumor cells should not be touching the edge of any of the sides of where you took out. But that means that it didn't matter if you were 1 millimeter away, or 5 millimeters away, or 3 centimeters away from the cancer, the recurrence rate was actually the same. Prior to these guidelines, we used to have fairly high re-excision rates, I would say. If somebody took someone to the operating room for a lumpectomy or partial mastectomy, the national average re-excision rate, meaning you'd have a closer positive margin and be taken back to the operating room for a second surgery, was about 20 to 25%. And actually with these guidelines, they're starting to look at some of the larger cancer centers, MD Anderson, Memorial Sloan Kettering, to see, are these guidelines decreasing their rates of re-excision? We're not taking patients back to the operating room as often, but still having the same recurrence, the low recurrence rate. And we're finding that our re-excision rates are coming down to about 13 to 15% in a few studies. So we're going to switch gears a little bit and talk about a presentation by Terry King on surgical considerations in patients receiving neoadjuvant chemotherapy. So the second topic about neoadjuvant chemotherapy is when we talk to patients about giving them chemotherapy before we take them to surgery. And then it becomes kind of a question in the surgeon's mind about exactly what do we need to remove when we go to the operating room. So neoadjuvant therapy decision-making, we know that there's, so far, hasn't been shown to be a big survival advantage whether you get chemotherapy before surgery or after surgery. That doesn't really change the survival. But it could allow for what we call downstaging of the tumor and making somebody that presents with a large tumor in a smaller breast that wouldn't really be able to have a lumpectomy for cosmetic reasons actually be able to shrink this down and become a good candidate for breast conservation therapy or lumpectomy, which can be very important. And there are, also with neoadjuvant chemotherapy, we look at this thing called PCR, or pathologic complete response. So we're looking at when we give you the chemotherapy and then we take you to surgery, do we see any cancer cells left over on that final pathology? And if we don't, we call that a pathologic complete response, meaning the chemotherapy shrunk your tumor down completely. And that can be dependent on the tumor type and the response of treatment. And there are different papers that show different pathologic complete response rates depending on what type of cancer and the type of treatment was given. But most patients with chemotherapy upfront will have at least a good portion of shrinkage of their tumor, which again can help us be able to offer different types of surgery to patients that might not have qualified. And they found there was no difference in recurrence rates if women got chemotherapy before surgery or after surgery. So when we think about how do we then decide what to remove when we go to surgery, there's a few different things that we can look at. So we use imaging. We use MRI often, which has the highest sensitivity and specificity and accuracy in actually estimating what is potentially remaining in the breast. And then we usually resect anything that still remains suspicious, clinically or radiologically. So either it feels or it looks on imaging like there's still something in that area. But we don't necessarily go to the operating room with the goal to remove everything that used to be there. That's not the goal anymore. So it becomes somewhat of a challenge for surgery. So this pattern of shrinkage, when tumors shrink, they can shrink a couple different ways. So the way we like them to shrink is in one actual ball where it shrinks down all together in one size. That will help make somebody that wasn't a breast conservation candidate into a breast conservation candidate if they do well with the treatment. But then there's this thing called the Swiss cheese, that's what I call it. So it can shrink in pieces, where the entire extent of what you actually still see on imaging or still feel is still the same size in the entire size of it, but it just shrunk in pieces. So that's one thing I always tell patients that are getting neoadjuvant chemotherapy is we hope that this downstages you and allows us to do smaller surgery, but that doesn't always happen that way. That doesn't mean that your tumor's not responding to the treatment. It absolutely is, but it just might not be responding in the way that will change our surgery. And there, we just talked about the guidelines for re-excision and margin guidelines, but we really have to be very specific in talking with our pathology colleagues and looking at the pathology to know if we take out a tumor and the patient had chemotherapy up front and we have a close margin, it might be an instance where technically the guidelines state that you're negative margin and you don't need to go back. But again, remember that Swiss cheese? If their pathology report says that this shrunk down to little tiny bites, you might kind of be concerned that maybe your margin is not negative. So you may still have to take someone back to the operating room for a re-excision, even though you technically have a negative margin. We have to decide that on each clinical basis individually. So the other important thing about neoadjuvant chemotherapy, and this is kind of one of the focuses I would say when I see patients that have certain types of tumors or the way their tumor presents, is somebody that we're looking at the axilla, the armpit, the lymph nodes under the arm. When somebody comes to the office and they have breast cancer that looks like it's spread to a lymph node under the arm, that's what we call clinically node positive, meaning either we feel something or you've maybe already had a biopsy that shows cancer cells in that lymph node. And we know if we give you chemotherapy, many patients will become clinically node negative, meaning if we felt something before the chemotherapy, we might not feel something as you go through chemotherapy. It starts to shrink down and get back to normal. Or if we do a biopsy after chemotherapy, it might be negative now. All those cancer cells are gone. Again, in the past, we used to say, doesn't matter, you had cancer in your lymph node, they all need to come out. Okay, we're kind of changing the paradigm. We're thinking, maybe we don't need to do that anymore. Maybe we can just remove 1 or 2 or 3, those sentinel nodes, and if they're negative, maybe you can keep the rest of your lymph nodes. So there's a lot of changes with the armpit. You can go ahead and move to the next slide. So again, if we become clinically node, or we are clinically node positive and we become clinically lymph node negative, this is a study that looked at that very question. Do we really have to remove the rest of the lymph nodes? And this was called the Z1071 study. And in this study, patients had a sentinel lymph node, and they all went on to have an axillary node dissection. And then they followed to see how many patients that had all their lymph nodes looked normal, how many patients still had lymph nodes behind those that were positive? And if they did it matter in terms of recurrence? And so what they found actually is if 3 or more lymph nodes were removed, meaning you got a really good sample, you got at least 3 lymph nodes out, and they were all negative, then the chance that you had more lymph nodes positive was less than 10%, which was their kind of cutoff. If it was above 10%, they were going to say, this study doesn't work, we need to be removing everyone's lymph nodes. But this showed that if the sentinel lymph node was positive, we still need to remove more lymph nodes. So we're not getting rid of axillary node dissection completely, but if we can convert you to an axillary lymph node negative, maybe we can save you from having to have all those lymph nodes out. So what they did in this study was, let's see, after neoadjuvant chemotherapy, patients had the sentinel lymph node biopsy and they check it at the time of surgery, okay? And if we couldn't find the lymph nodes because it didn't map well, or if there weren't 3 lymph nodes, there was only 1 or 2, patients were following up with axillary node dissection during that surgery while they're asleep. And again, if there were 3 or more lymph nodes removed that were negative, they were not moving on to axillary node dissection. So currently there's 2 clinical trials looking to kind of validate this study and also determine what other things might need to happen. And we are actually participating in these trials, so our patients are signing up for these trials and helping us get this information, which is very important. But these are 2 trials looking at this exact same case. A patient that has positive lymph node, gets chemotherapy, becomes clinically node negative, and then we go to the operating room. And if they decide to sign up for the trial, we check their lymph node at the time of surgery while they're asleep. And if they are still positive, they get randomized while they're asleep or after, if you decide, to either have the axillary node dissection and have some radiation, or not have the axillary node dissection and just have some radiation. So that's one study that we're looking at right now, and we're trying to figure out, can we leave the rest of those lymph nodes there even if they're still positive? The other study is if that final pathology from that surgery comes back that those lymph nodes really turned negative and they are negative, then we're looking at, do we have to do anything else? In that situation, we're not doing any more surgery, but maybe we still need to do radiation, or maybe we don't. We still have a lot of questions, and this is exactly how we got to where we are today, by answering questions like this, and these are the current questions that we're asking. So I just have maybe 2 or 3 more slides kind of talking about newer things that are coming out. This is a study that looked at something called the radioactive seed localization versus wire localization of non-palpable in situ and invasive breast cancer. And so what this study looks at, and as any of you in this room that have had breast cancer or know somebody that's had breast cancer that had a lumpectomy, we know if we can't feel the tumor, we need the radiologist to help us find it the day of surgery. So generally, we will go to the radiology suite, they will put in a wire into the breast, it's called a wire localization. That wire goes into the breast and it sticks out of the breast. You get transported back over to the pre-op area where you see us, and then we go and we take it out. There can be a lot of problems with this. So first of all, we can't do the surgery at 7:30. Surgeons, we like to start work early, okay? So we can't do the surgery at 7:30 because you got to go get your wire. So now we can't start till 9:30, 10, 10:30, something like that. Also, what if it moves? What if it gets put in when you're in compression in the mammogram, then they take you out of compression, all of a sudden the wire's here, your lesion's here. Doesn't happen all the time, but we have to be really creative when we go taking these wires out. And sometimes it can be really difficult. So they're trying to come up with tons of different ways to localize lesions in the breast. And one of the ways is, that probably the first one that came out, is this thing called the radioactive seed. If anybody's ever heard of anybody having radioactive seeds placed for treatment of their prostate cancer, it's actually the exact same seed. It's iodine 125. And we have a little Geiger counter, a little wand in the operating room that we use that we can set to I-125 and makes this super high-pitched sound when you're right over the seed. And I have some experience with this because where I trained, we did this. And then I had to go back in space and go to wires again. So that's where we are here. But so the seed you can find right over, you just put the wand right over the breast and you can find exactly where it is, right exactly where the lesion, right exactly in the area that you want to take out. So why is this important other than helping us figure out where this is? They were looking at, could this help us with our margin status? Could this help us with the weight of the specimen? Could it help us with the length of the surgery? Could it change our complication rates? And actually what they found was it doesn't really do any of that in most of the studies. Some studies showed that there might be better margins, but most of them showed it wasn't. It was mostly just that it can help us logistically in a lot of different ways. And I'll tell you, there's a few different companies coming out with non-radioactive seeds, so things that we don't have to worry about the radioactivity, we don't have to worry about following that seed, making sure it doesn't get lost because of the radioactivity, and hopefully in the future, we'll be able to switch to something like this potentially, where we can help be more direct and localized without that wire. And this one last slide, just looking at kind of what's new, latest, and greatest, and who knows if this will make it anywhere, but if it does, it's really awesome. So this is coming out of San Diego. It's called the intraoperative tumor detection using a radiometric activatable fluorescent peptide, blah, blah, blah. So basically what this is an injection that gets put in the day before surgery. And then you go to the operating room and we do the lumpectomy in the sentinel node. And guess what? If we have a positive margin, it looks neon green to our eyes when we take a picture of it. So this was a phase 1 study, which means the very earliest study out there looking at can we identify tumor cells? And I actually just was at a conference last weekend and met the surgeon that's kind of spearheading this. And basically what he did was he created a molecule that when it gets inside of a cancer cell, it gets cleaved or broken, and that lights it up. So it's not going to light up in an area of inflammation. It's not going to light up just because your scissor or whatever you're using in surgery gets close to it. It lights up by the cancer cell. So they actually just finished this phase 1 trial, and they're starting the phase 2 trial to look at actually implementing this in the operating room and seeing does it work. And what they're going to do is take pictures, and if you see green, you're going to take more margin, and then we're going to see what the pathology report shows and see if it correlates. If it correlates, this could be novel in trying to figure out with your blind eye, where is my margin?